أهلا وسهلا بالجميع. يعطيكم العافية جميعا. It's my pleasure to welcome you today to our session. Actually, I will be co-moderating this session with my colleague, Dr. Rony Zeenny. So, next slide, please. It's my pleasure to welcome Professor Carla Irani, who is the head of the Department of Internal Medicine and Clinical Immunology at Hôtel Dieu de France and president of the Lebanese Society of Allergy and Immunology, an American board diplomat in both internal medicine and allergy immunology, and a fellow of the American Academy of Allergy, Asthma, and Immunology with extensive clinical and research expertise and numerous publications in leading international journals. So Professor Irani will talk to us today about primary immunodeficiency. It's our pleasure to welcome you. It's our pleasure also to welcome all the colleagues from the Order of Pharmacists. This is the second webinar we are having. It's a pleasure to be here to again resume our activities after the long period of war that we had, and we hope that it will really end soon. So Professor Irani, the floor is yours. تفضلي. We are honored to have you.
Thank you very much, Professor Salameh. I would like to thank the organizers, the Lebanese Order of Pharmacists, and also Dr. Carla Irani for this opportunity. So I'm trying to actually share my documents that we did before, and it worked. So let me see. Okay, here it is. All right, I hope you see it. It's fine?
Yes, perfect.
Okay, very good. Okay, so just a reminder that this, again, it's a great opportunity, and the reminder why we started this the idea of doing a conference about primary immunodeficiency is because this is the Primary Immunodeficiency Week around the world. And the slogan this year is "We Can't Wait, Advancing Early Diagnosis and Timely Care for PID Patients." We will talk about particularities in Lebanon. We can't wait. We will see why it is important to treat early. Just a small reminder about the component of the immune system. So the immune system, it has two major components, starting from the hematopoietic stem cell, the myeloid and the lymphoid. And as you see, all the cells that are here from the eosinophils, neutrophils, T cell, B cell, NK, natural killer cells, they are all affected or may be affected when we talk about primary immunodeficiency or innate error of immunity. We also have the lymphoid organs that's where the production of all the T cells, B cells is going on. And we know that the thymus, for example, is the major organ where we have the maturation and apoptosis of the T cells, so the tolerance of the auto T cells, etc. We have the complement system, we have the bone marrow, lymph nodes, etc. So all these are important in the immunity. For example, the B cells are very important for humoral specific immunity because they are the cells that produce antibodies. And when we talk about immunodeficiency, we think that it's mainly antibodies deficiency, but we will see that T cells may be implicated as well. The antibodies have a major role in binding and neutralizing viruses and toxins. They can form also immune complexes with the complement, and they can work as for opsonization for phagocytosis eventually. T cells are much more important, and we know that we cannot live without T cells. We know that the T cells are immature, produced by the bone marrow, and then they go to the thymus for maturation. This is what we call the cellular immunity. That is the most important immunity because Also, the T cells will actually help the B cells for antibody production. So people can live without B cells, but not without T cells. The complement is a group of soluble proteins that also are important in assisting the immune system for phagocytosis, or to amplify, and that's why it is called a complement system, to amplify the immune response. So when we talk about primary immunodeficiency, as I mentioned, we also call them innate error of immunity. We talk basically about conditions where the immune system are caused by defects, whether it is inherited or de novo genetic. And we know that more and more we have genetic testing in order to really see the main cause of the innate error of immunity. We have multiple genes that are affected, and every day we have new genes. So now, for example, in 2026, we have more than 550. I know here it's 400, but from 2019 till 2026, we have even more genes that are discovered. The incidence is not very high, but in our part of the world, it is actually high. There are multiple categories that were described in the International Union of Immunologic Societies. Basically, it's important to think like this. Is it an immunodeficiency that affects cellular or humoral immunity? Is it a combined immunodeficiency with some syndromes? And we'll see some examples. Is it only antibody deficiency? Is it an immune dysregulation? So they are there, but not functioning well. It can be phagocyte problem, intrinsic innate immunity. It can be autoinflammatory disorder. So even these are included in the primary immunodeficiency. It can be complement deficiency or bone marrow failure syndromes. So basically, for us, when do we think about immunodeficiency? We know that this is mainly manifested as infections. They are frequent, severe, with unusual organism, difficult to treat, and in children, mainly failure to thrive. So failure to have a normal curve of weight and height. But these symptoms can start with autoimmune disease, so not infections, but autoimmune disease that are frequent also or unusual. It can be manifested as immune dysregulation, impaired tumor surveillance, lymphoproliferation, prediction to severe atopy or malignancy, and finally autoinflammation, such as the syndromes of fever, rash without infection. The warning signs of immunodeficiency are not actually very specific, because these signs can be present but not have immunodeficiency. But anyway, when to think about immunodeficiency? For example, in children, we know that ear infections are very common, whereas in adults, if you have a lot of ear infections, you have to think about immunodeficiency. 2 or more serious sinus infections, use of a lot of antibiotics, need for IV antibiotics, recurrent pneumonia. As I mentioned, in children, mainly failure to thrive, so to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent rash in the mouth or fungal infection of the skin, the need for many IV antibiotics to clear infections, and seated infections such as septicemia. But one sign is very interesting, is the family history of primary immunodeficiency that is very related to immunodeficiency. So how to make a diagnosis? Actually, the medical history and the family history are the most important part of the high index of suspicion, or like to make a diagnosis. And then we go to infection history, thinking about the range of pathogens. Is it common versus opportunistic? The sites of infection, the length of the illness, and the frequency, and the growth and development. later on, the physical exam is very important because sometimes, for example, in some disease where you don't have lymph nodes, which is the X-linked A gamma. So just seeing a child with absence of adenoids, for example, in a very early age can lead us to high suspicion. Lab testing, we know, for example, in children that we have more lymphocytosis. So lymphopenia in a child can also lead or make us suspicious about this diagnosis. And finally, if we have a high index of suspicion, we need to refer to an immunologist for specific diagnosis and treatment, genetic testing, and co-management with primary care. So the pattern of infection, the most common whenever you have antibody deficiency is the bacteria, mainly pneumococcus, Haemophilus influenza, Moraxella, Staph aureus, meningococcus, Pseudomonas, Mycoplasma. Some viruses are also common, in particular enterovirus, rotavirus, and with the parasites infection, mainly Giardia. When we talk about combined immunodeficiency, so T cells and B cells, we start having more severe infections. So more important bacteria such as Listeria, enteric flora. The viruses are more aggressive, such as herpes, influenza, measles. We can have fungi such as Pneumocystis, Candida, Cryptococcus, and the protozoa such as Toxoplasma. So when you have combined immunodeficiency, as I mentioned, T and B cells, it acts like the secondary immunodeficiency, the most common HIV, but it's like the same. It is kind of severe. When we have a phagocyte defect, the pattern of infections can be different also, mainly with Staphylococcus, Pseudomonas, Salmonella, mycobacteria, because we know that we need phagocytic activity to clear out the mycobacteria, in particular with the fungi, Aspergillus and Candida. And this is very common with the syndrome called CGD, or chronic granulomatous disease, or where we have infection of intracellular bacteria, in particular mycobacteria. The complement deficiency, the pattern of infections can be also specific. These are mainly encapsulated organisms. We know that with the last part of the complement, it's Neisseria or pyogenic infection. But also what's one of the manifestations of complement deficiency can be not infections, but autoimmune disease, in particular early onset systemic lupus with a C1, C2, C4 deficiency, or a typical autoimmune disease such as hemolytic uremia syndrome or other autoimmune disease. So this slide is very busy, but it shows you that basically we have some syndromes presenting with primary immunodeficiency and autoimmunity. And what's interesting here is that many of these diseases, we found the genetic cause. And some of them actually you can treat by repairing this gene. And that's what's interesting. And each genetic defect will give a particular syndrome, whether clinically or lab or immunological testing, that will actually lead us to the proper diagnosis. We have some what we call primary immune regulatory disorders, also clinically presenting with autoimmunity, in particular cytopenias. So these are patients who have autoimmune cytopenias, whether anemia, thrombocytopenia, or neutropenia. There you have to think about primary immunodeficiency or organ-specific autoimmunity. As I mentioned, of course, infections. And basically, here it is interesting to do, as in all primary immunodeficiency, genetic sequencing. One of the tests that we use actually in diagnosing primary immunodeficiency is flow cytometry, where you can actually measure the T cells and B cells with the markers that are correspondent, such as CD19 for B cells. And it can show the flow cytometry even other cells, such as natural killer or other cells implicated for the immune system. I will talk some of really the most common symptoms that we can see. For example, we can see the X-linked A-gamma globulinemia, where it is, as you see, related to X, so it's mainly in male. A-gamma, so complete absence of immunoglobulin. And here the infection, we have infection susceptibility, pyogenic infections, viral meningoencephalitis, poliomyelitis after a vaccine, mycoplasma arthritis. These mainly, because they are very severe, they will start in early childhood, recurrent sinopulmonary pyogenic infections, and some of them have neutropenia. So basically, the diagnosis of this syndrome early on is very important. We do flow cytometry. We have no B cells. Almost 50% of these patients have positive family history, and that's why family history is very important. The immunoglobulin level is usually very low. I'll give you an example. The normal would be above 600 milligram per deciliter. So here it's less than 100. B cells are almost absent, and we can have normal T cell number and function. Other syndromes, we have the hyper IgM syndrome, where we have a high IgM but low IgG. There's where there is a problem with switching from IgM to IgG that is lacking. We have the common variable immunodeficiency, which is the most common diagnosis in adult. We can have some subclass deficiency. We can have specific antibody deficiency. But most importantly, sometimes we can have transient hypogammaglobulinemia of infancy. So these children may have low immunoglobulin levels in very early childhood, and then it will go up after age of 3 years. And I will talk a little bit about the treatment. So as I mentioned, in adults, common variable immunodeficiency is the most common. So we have infection susceptibility for bacteria, mainly respiratory, mainly pneumococcus, Haemophilus influenza, so what we call encapsulated organism. Basically, because they are respiratory bacteria, they cause a lot of sinopulmonary infections. Patients can present with bronchiectasis that are due to these recurrent infections in the lungs, diarrhea, arthritis, giardia infection, autoimmunity, sometimes asthma, lymphoproliferative disease, and sometimes complicated with some types of cancer, in particular gastric and lymphoma. So this is sporadic most of the time. So the presentation actually occurs in the age of 20 to 30. So this disease starts relatively late. So relatively late compared to the other manifestations that can present in childhood. And basically for this disease, the diagnosis is to show that we have low immunoglobulin levels, IgG, it's the most important, plus low IgA or IgM. But sometimes the numbers can be within normal, but we have an impaired antibody response. So the numbers are okay, but the immune system doesn't function very well. This slide actually shows that in few cases, because we have a low IgA, there is a predisposition of something called like celiac-like disease. So here we have predisposition to celiac. We have low IgA. Because we have IgA that is low, we cannot measure antitransglutaminase. But also when we have this case with low IgG, for example, we have to think about coexistence of both diseases. More severe are the cellular and combined defects. So here the problem is not only B cells, but B and T cells. That's the syndrome that we call SCID, severe combined immunodeficiency. These are rare syndromes. We have many genetic etiologies. What's interesting is that because we have some genetic etiologies, we can have replacement. For example, with the ADA, the adenosine deaminase deficiency, we can have replacement of this enzyme and almost cure the child. We have other genetic syndromes such as RAG1, RAG2 deficiency, etc. And we have some combined defects with few syndromic features such as the Wiskott-Aldrich and ataxia-telangiectasia. So these patients present with rash. They can have low platelets. The DiGeorge syndrome, that is mainly some special facial features with T cell deficiency. And this is a very interesting syndrome because it can even manifest partially in adults. So the parents of the child have this, but they live to adulthood, whereas the child can have it very severe. So the SCID, because it's severe, it is important to avoid live vaccines because they may develop the disease. Of course, these have opportunistic infection, as we mentioned, the pneumocystis carini, severe bacteria, severe viruses. It can be X-linked most commonly. And as I mentioned, in early childhood, we have lymphopenia, which is unusual in pediatric. These children may still have some maternal T cell at very early age, but then later in life, they lose this maternal protection and they have a problem with the T cells. So the SCID is a syndrome that needs to be diagnosed very early on. Otherwise, it is fatal. So these children, unfortunately, they don't live at older age. The cure is stem cell transplantation with a great success rate if it's done very early in life. And we're talking 3 to 6 months. And sometimes, as I mentioned, we can have gene therapy. Of course, we have adjuvant therapy that we can use in the beginning, such as the immunoglobulin replacement, IVIG, prophylactic antibiotics. But what's most importantly is to avoid live viral vaccines when we need blood transfusion to irradiate this blood and to give CMV negative blood products because these patients are prone to many viral infections. Other congenital defects, phagocyte number, function, or both, chronic granulomatous disease, Shinya-Kikuchi, leukocyte adhesion deficiency is very interesting because these children, they actually have a problem with the cordon umbilical. So they, instead of losing it very early on, it lasts because they have a problem with everything that needs like adhesion of the white count to, for example, repair the skin or the lesions. So this is something to, like a hint to think about this deficiency. And we can have other problems with neutrophils and congenital agranulocytosis. I will talk a little bit about our part of the world. So the innate error of immunity that are very common in our part of the world, just because we have a lot of consanguineous marriages. And unfortunately, these are low-income countries. Many of these regions don't have a good molecular diagnosis. We are fortunate in Lebanon to have actually good genetic study. So again, we have a lot of consanguinity that is a risk for infection. The incidence of primary immunodeficiency is expected to be 20 times higher in the Middle East compared with North America and Europe. And in some countries, for example, in Egypt, it is very high. But what's more important is that there is a diagnostic lag it means the interval between the onset of the disease and the diagnosis can go up to 45 months. And that's a problem because that's where you lose the opportunity to start treating early. So this is a table. I know it's very busy, but for example, if you see in Lebanon, it's the registered IEI patient that we published here as a consensus in 2021 was not very high, but that's because we don't have a official registry that we hope to have very soon. The high diagnostic yield in the MENA region is due to high incidence of parental, as I said, consanguinity. And again, molecular diagnosis will help appropriate clinical management, prenatal diagnosis if you have a family history, and targeted therapy. How can we improve the diagnosis and the treatment? Many times we need a prenatal diagnosis in childhood onset patients. We need better access to intravenous immunoglobulin replacement therapy. This is a costly therapy. Many times we don't have a good access to this treatment. There was a big shortage of IVIG, for example, in the 2021-22. And we do have a newborn screening that is approved by the Ministry of Health in Lebanon. This is very important because it will save these cases of severe combined, but it's not implemented officially. So we have the track analysis that is part of neonatal screening. Again, a shortage of IVIG is a problem, poor venous access to the hospital, and also a problem with hematopoietic stem cell transplantation, which can be life-saving to these patients who have severe immunodeficiency. So we have a high mortality, unfortunately, especially with the SCID cases. We need to introduce personalized therapy for these patients. We need to refer more for molecular defect testing, genetic testing, and of course, we need to refer to more immunologists. And many times, the ideal would be to do a pre-symptomatic diagnosis, but of course, this is very challenging. So the steps to be taken is one of the steps is our conference today to increase awareness about innate error of immunity in order to improve diagnostic capability, improve the access to stem cell transplantation, to have more trained young physicians, to have more immunologists, and of course to address the most important economic burden because these treatments are very costly, not only for IVIG, but also for the complications, for the infections, antibiotic use, etc. What is the treatment? So the treatment is based on two things, mainly when we are talking about immunoglobulin replacement. So for severe combined or genetic syndrome, we have either the bone marrow transplantation or the enzyme replacement. So the gene therapy is also an option. But for now, practically, especially in combined or common variable immunodeficiency in adults, fortunately, we can give them a good quality of life, almost not a cure, but to give them a normal life with the immunoglobulin replacement. And we have in Lebanon two kinds. We have the intravenous, which is an IV infusion every 4 weeks in the hospital. It can be done half day. And relatively rare systemic side effects if it's done properly. The only problem is the accessibility and the cost. And the starting dose is 600 milligram per kilo. What we do when we do IV or subcutaneous is we measure the immunoglobulin level after 3 weeks to make sure it's always above 600 milligram per deciliter. The other option, which we are fortunate to have also in Lebanon, is the subcutaneous immunoglobulin. that can be done so subcutaneously. Ideally, the goal would be that these products will be self-infused at home. We still don't have the pumps or the training, so we do a subcutaneous immunoglobulin replacement now at the hospital. And also the dose is same for a total month, but it is splitted every 2 weeks. So my last slide is the take-home messages. The take-home is that humoral immunodeficiency, it's true that it's rare or even combined, it's very rare, but we have to think about it when there is a high degree of suspicion, if we have unusual recurrent infections, if we have a lot of unusual autoimmune disease. One of the best predictors is family history. And fortunately, we have a treatment for the most common humoral immunodeficiency. We may have treatment even with the severe combined. The most important is that the treatment should be installed as early as possible, because we know that untreated patients will have a lot of complications that can affect quality of life, knowing that these complications can be irreversible. So with that, I would like to thank you for your attention.
Thank you so much, Professor Irani, for this really eye-opening presentation on PID, pathophysiology, and prevalences. Before we start taking questions, eventually we do have one question written in the Q&A. I'm going to go ahead and read the question. If the genes responsible are mostly mapped, can they be tested at the embryo level with prenatal genetic testing? And if so, can the affected genes be rewritten by CRISPR or by viral loading, thus curing the patient before even they are born? This is a question by Ahsan Karaki.
Okay, so this is a tough question because, of course, in theory, it can be done. The gene therapy is not, even in the modern world, it's not available for all genetic defects. So yes, in rare cases, if it's a particular gene where we have a treatment with gene therapy, it can be done. But I think the most important is not only prenatal, but at least if we implement the TREC testing, so the screening with the newborns, this can save lives.
Right. Thank you so much. Do we have any question from the attendees before we move to our next session? Meanwhile, I have a quick question. If really we would be we have the magician in hand and we would want to have the magic stick, what would, in your opinion, what would be the one thing that you would prefer to have that will improve, in your opinion, one thing rather than recruiting immunologists? If you really believe that one thing can make an impact in Lebanon, and if we really can orchestrate our effort to make it happen, what would be that one thing that you believe it will improve the PID patients' life in Lebanon?
Okay, so one thing is to think about the disease. So this is more common than we think. And I would love to have early diagnosis because it will spare patients a lot of suffering. My second wish is to always have accessibility to immunoglobulin replacement therapy.
All right. Professor Salameh, you have a question?
Yeah, actually, thank you. Very enlightening presentation, Professor Irani. You talked about a soon to have a registry. Are we having this kind of registry in Lebanon? Because, I know that for a lot of diseases, some people tried to have a registry and it was tough, it was difficult. And then most of the registry in the Ministry of Health are not working. So is there a possibility to have that within the order of physicians with the scientific societies. I don't know if there is a possibility to have this kind of registry. This is first. And second, I think there's a lot to do from the prevention point of view. You talked about consanguinity, and I think that this is a problem that we have in Lebanon. There's a lot that can be done before people reach the diagnosis. I think that it is important that we as healthcare professionals also are aware of all the possibilities of preventing that from happening. And if we have patients, of course, I think my other colleagues will talk about the management and the preventive measures after diagnosis. But before diagnosis, what do you think about this registry issue and what can be done at the level of public health?
Okay, thank you so much for this beautiful question. Having a registry is very challenging, yet we have many epidemiologists, such as yourself or others, but as you mentioned, even in other diseases, it was tough to do a registry. But this is a rare disease, so a registry here should be easier and more needed. But anyway, I think the main problem, and I'll be honest here with you, is everybody is worried who owns the data. Okay, so whenever we approached other specialists to do the registry, and even the International Patient Organization, the ALPPI, they have collaborative registries in Europe, for example, with other countries that were done because it was initiated by patients. So the problem is who owns the data. I think we should work on a registry still. We shouldn't give up. I tried many years ago and I failed because everybody was worried about the data property. But I think with your help, the help of many epidemiologists, this is much needed and very important to have. So this is the main problem. So hopefully we can reach something, we can discuss it. I mean, but this is much needed. For consanguinity and again, I think we should work with public health officials, with epidemiologists, with pediatricians, etc., about this pre-diagnostic measure or high index of suspicion in order to help better diagnosis.
All right, thank you.
Thank you for the question. We have one question in the Q&A. What can be our role as Lebanese pharmacists to help with the early detection or referral of suspected PID cases?
I think the role of pharmacist is crucial. We know that patients go trust their pharmacists, and this is a wonderful thing. I think even pharmacists should actually be the key, how you call it, the police of antibiotic use and prescription by many physicians. So I think pharmacists should actually be the controller of this frequent use and abuse of antibiotics. So that's the main role of pharmacists. And I know that patients, they trust their pharmacist a lot. And so that's where the awareness is very important.
All right. So having this being said, eventually I received a question. What are the most common red signs or warning signs that a pharmacist should watch for that might suggest a patient is underdiagnosed for PID?
Mainly recurrent infections. Recurrent infections is the main important sign. Failure to thrive in children and severe autoimmune disease or severe infections.
All right. Thank you so much.
Thank you.
If we have no more questions, then I would like to thank you, Professor Irani, for your really presentation and time with us. You're going to be staying with us for the Q&A
Yes.
at the end.
Sure.
Meanwhile, we're going to be moving to our next speaker, Dr. Jad Ghaddar. He's a clinical oncology pharmacist at the American University of Beirut Medical Center and a board-certified oncology pharmacist currently practicing in Lebanon. with a strong background in clinical research and oncology pharmacy practice. His talk will be mainly the pharmacist role in PID from dispensing to care coordination. The floor is all yours.
Okay, so hello everyone. Do you hear me, everyone?
Yes, we are able
Okay.
to hear you quite well.
So I want, before I start my presentation, to thank you, Dr. Rony, and thank the organizer for this very important webinar, to give me the opportunity to be with you, to talk in this very important webinar on a population that is very near to my population, which is oncology and hematologic patient, in terms of dysregulation and immunity. So without
Excuse me, Jad, please, if you can switch the display because we are seeing the presenter view.
Okay. All is good now?
We are still not able to see the screen. Now we can.
Okay.
But you
Can
have
you
to
put
do that.
slideshow? Okay, perfect.
Alright.
Thank you.
So as I have said, I will start my presentation entitled Improving Primary Okay, do you see my screen?
Yes.
Okay, so I will start my presentation with entitled Improving Primary Immunodeficiency Care. What are the treatment options, and what is the management from a pharmacist perspective? So first of all, I have nothing to disclose, and this is my learning objective. So at the end of the presentation, you should be able to recognize the clinical manifestation and diagnostic challenges, to understand the pathophysiology, to explain the role of immunoglobulin replacement therapy, to differentiate between IVIG and subcut IG, to evaluate a cost effectiveness of IVIG versus subcut IG, and to apply pharmacist-led strategy to optimize treatment, increase monitoring, and increase patient adherence. And rapidly, this is my outline. I will start by a little introduction. Well, I will start by a sentence that Dr. Carla Irani have said. بس ما كنا متفقين على PowerPoint. So the PID is more common than you think. So effectively, when I was starting preparing this presentation, I was shocked by the number of patients who are living with PID, which are estimated about 6 million around the world. But the main challenge that we have is there is an estimation of 70 to 90% of those patients remain undiagnosed. And here it is a clear unmet need that we have to work on it. Why we have the big number of patients who are undiagnosed? First of all, because we have a lot of type of PID. Dr. Carla Irani have explained that we have a lot of gene, a lot of subtype of PIDs that differ one from another. So if you look on your right and you see the pie chart, you can see the most common one is the predominantly antibody disorder, where we have less production of antibody, or we have the number of antibody, but those antibody are not active. So those patients will have a recurrent infection, a recurrent hospitalization, and all the problem with antibiotic resistance and all of that. The second problem, which is the predominantly T cell deficiency, and you know the T cell is the chef d'orchestre. It is the Treg who does the regulation with the immune system, who will increase the production of plasmocyte, decreasing the production of clone of lymphocyte CD8. And it is very important in my practice area in oncology, because every day we have some cells that are mutated, because we have the mitosis, and the mitosis have a long DNA. So every time we have a mutation in those cells, and it's the role of the strong competent immune system of the body to kill those cells. So if those cells skip the immune system, it will proliferate, and we will have tumor or we will have increase in blast, and etc. The third most common one is the complement deficiency. Dr. Carla talked about it. So we have, the cascade of complement that will increase the inflammation, increase the interleukin, increase the cytokine to recruit white blood cells to cure the infection. So with a problem in this cascade, we will not have a strong immune response. And finally, we have the autoimmune dysregulation, autoimmune and immunodysregulation syndrome, when we have dysregulation and the immune system start to attack the self organ. So we understand now that we have multiple type of PID. Those multiple type of PID will consequently have multiple manifestation and not just infection. So we'll have autoimmunity problem, inflammation problem, allergy, malignancy, and immunodeficiency. So from manifestation, we understand the presentation. So patients who have different manifestation, for example, for patients who have a repetitive infection and a respiratory infection, will go to a respiratory medicine. Other patient will go to a gastroenterologist. Other patient will go to a hematologist. But the problem here, and this problem is the cause of those patients who are undiagnosed, that the disease is not cured by the specialist who is the immunologist. The disease will create some manifestation, and those manifestations will go to other specialty of physicians that will cure the symptomatology and the manifestation and not cure the disease. So we see we have overlapping pathway that emerge in a single disease, and that's why this webinar and increasing the awareness about the PID is crucial, and it's very important. So by this slide, I end citing the type of PID, what are the manifestations, and how it is presented. And I go to pathophysiology. There is a lot of pathophysiology in PID, but I summarized more or less the most common one, because those side effects are important for us as pharmacists because we can work on it. So first of all, we have the gene mutation. Dr. Carla Irani have said that we have more than 500 mutation of gene. So this gene mutation will do a problem and dysregulation in the immune system. So we'll have a decreased number of production of antibody due to a problem in the B cells. And what we have as consequence, we have recurrent bacterial infection with encapsulated bacteria, and poor vaccine response. The second group is lower cellular immunity. We have non-functional T cell, so we'll have severe infection, viral infection, opportunistic infection like cystitis, fungi. We have immune dysregulation and increased risk of malignancy. And finally, we have the phagocyte complement problem with a decreased number of opsonization and impaired to killing pathogens. So we have recurrent abscess, infection with catalase positive organism, and poor wound healing. So going further to understand more the immune system, how it's work. So in the normal case, we have a cell who are presentative of antigen. Those cells will present the antigen for the Treg cell. So those Treg cell, which is the Schaffner cast, will increase the clone of certain lymphocyte B, which is transformed on plasmocyte, and those plasmocytes will start to produce the antibodies that neutralize this bacteria or this epitope, etc. Another action of the Treg, it will wake up a T cell D8 to tell her, look, there is a mutation, and some cells, those cells are not differentiated well, so come and kill them. But what is the problem in the immune dysregulation? We will have multiple mutations like STAT, PIK3, CTLA4, complement deficiency. Those problems will mask the response and will dysregulate the response, and then the Treg will not respond in good way to any aggressors on any bacteria or any multiplication of malignancy, because we have a problem on those gene. So we understand now that there is no one problem in the PID. We have multiple problems. One is the infection, and the second point is the dysregulation of the immunity, which can create a autoimmune disease. So for this reason, physician and immunologist have to walk a fine line. If you look on the cliff on the right, on the right, the photo. So there is a fine line to walk on it between the immunosuppression of those inflammatory components while not exacerbating infection in a and an immunodeficient setting. But why we are talking a lot about PID and why early diagnosis of PID is very crucial, as the first speaker have said, because the delayed diagnosis have very big problem and in terms of mortality. So what happened? First of all, the patient start to have complication like severe and recurrent infection. And those severe and recurrent infection will lead to an end organ damage, like multiple respiratory infection will lead the lung to have bronchostasis. Bronchostasis plus infection plus development of inflammatory and autoimmune complication equal malignancy. Malignancy increase the mortality. So every time we diagnose in a delayed way the PID, we will be like an example of the Titanic. We will hitting the tip of that iceberg, because we will have a lot of problem because of delayed time of diagnosis. So what are the strategies that can be implemented to avoid delay? First of all, a medical education, like as I have said, we have multiple physicians and multiple specialization of physicians that are looking for patients with PID, and they don't know that those patients are PID. So it's very important to explain and giving awareness of this type of disease, to give him the reflection, to refer him to immunologist and refer him to a specialist. The second point is newborn screening for inborn error or of immunity. And the third point is antibody deficiency screening, which is we can calculate the total of globulin when we do the total protein minus the albumin. It starts to be a screening worldwide in different countries around the world. One of these countries are the Brazil, but we don't know until now the outcome of this the study or the screening way. So I have put the slide, and Dr. Rony have shared with us a question that this slide can help to answer this question also. So as Dr. Carla have said, that the pharmacists have a key role in the PID. Why? Because the time of contact. You know, every time a patient will be hospitalized, or every time the patient will go to a doctor, it will be for a period of time. But the pharmacist, and especially the community pharmacist in the area of the patient, will live with the patient, because every month this patient will go to his pharmacy, he will buy his chronic medication. Every time he has infection, he will go and buy the antibiotic for this infection. So for this reason, raising awareness between the community pharmacists is very important, to have the reflection. So I have put 10 warning signs, which is the big important signs. And on the left, we have the 3 major signs. Once we detect one of them, we should refer the patient to a specialized immunologist to see if the patient has PID or not. So the 10 warning signs are 4 or more new ear infection within 1 year, 2 or more sinus infection within 1 year, 2 or more months of antibiotic with little effect, 2 or more pneumonias within 1 year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscess, a persistent thrush in the mouth or fungal infection on skin, need to intravenous antibiotic to clear infection, 2 or more deep-seated infection, including septicemia, and a family history of PI. Those 3 important on my left are 3 important points. Every time we see those patients, we should refer them rapidly to an immunologist. First of all, 2 or more serious infection, of course, in course of a year, and especially if the patient does not have any other problem like cancer or HIV or whatever. The second point is need to resort to intravenous antibiotic to clear infection, and finally a family history of PID, which is often missed. So what are the guiding principles for management of primary immunodeficiency? So we have 3 components where we can work on it. First component is the replacement of immunoglobulin therapy, which is the IGRT, which is substitution therapy, which the base of the treatment of the patient with primary immunodeficiency. The second point is management of complication, and the third point is the curative approaches. The curative approaches is for severe type of PID like SCID, which is severe combined immunodeficiency, where we can do a bone marrow transplant. But the problem here in bone marrow transplant, you use harsh medication as IV4, IV2, is the after BMT. The patient can be cured, but in our experience, every patient have immunodysregulation before transplant, and we go with transplant. Those patients are the most vulnerable patient to develop GVHD. So we should, every time we have primary immunodeficiency, we should balance between the curative positive thing and the GVHD, which can be very tough on certain patients after bone marrow transplant. Returning to the pathophysiology, and here I choose every therapy that can inhibit the cause of the consequence manifestation of the PID. So first of all, we have the immunoglobulin replacement therapy that will reduce the problem in antibody production, because we are giving outside antibodies. We have the antibiotic prophylaxis if we have recurrent infection. We have as I have said, the bone marrow transplant and the immunosuppression field with GVHD. And finally, we have the interferon gamma targeted therapy with interferonopathy. So let's start by the PID. As you know, the PID, as I've said before, it's the base of our treatment, because we are supplementing the patient antibody who are not active or who are produced on a very low level. So a PID is a regulatory approved indication for a human normal immunoglobulin, for which all available products are licensed. Establishing PID diagnosis indication for immunoglobulin replacement therapy is crucial for clinical outcome. One important point here is immunoglobulin replacement therapy should not be interrupted once a definite diagnosis has been established. And this is a big problem in Lebanon, especially now where we have a shortage, a wide and national shortage of IVIG and immunoglobulin replacement therapy. Those patients who have PID are in a big danger. The starting dose is 0.4 to 0.6 milligram per kilo every 3 to 4 weeks in IV route, and 100 to 200 milligram per kilo per week in subcount route. We continue we continue the adjustment individually based on the trough level and the clinical manifestation of the patient. So you will ask me, Jad, does the immunoglobulin replacement therapy works? I will answer by yes. Multiple meta-analyses have showed that every time we have higher trough level in PID patient, we have less need of antibiotic and less infection for those patients. And we have a lot of statement on the guidelines that are recommending to give immunoglobulin replacement therapy for patients with PID. So what every pharmacist should know about IVIG? First of all, we will talk about the IV route. So whenever we give IVIG, we are giving protein, which is a chimeric protein in the blood. When we are talking about infusion protein, we will have infusion-related reaction. So what are the infusion-related reaction syndrome? We have headache, fever, chills, hypersensitivity. What we should do? We should give the pre-medication with paracetamol, antihistamine, and corticosteroid if we have prior reaction. And we can monitor the rate. So we start the rate at 0.5 to 1 milligram per kilo per minute, and we increase every 15 to 30 minutes if tolerated. The maximum rate depends on two things. We will talk about later on this slide: the product variability and the concentration of the product. The second point, and it is very important point, is the dosing, dosing and obesity on obese patient. You know, IVIG, it's an antibody, and the antibody is polar entity. So it's spread only in the aqueous place in the body. So he has a very strict volume of distribution. So every time we add fat, we should not calculate the dose on the actual body weight, but we should, as pharmacists, give the reflection and to calculate the dose on the adjusted body weight. The third point is the renal safety. We have risk of acute kidney injury. Why? Because we are infusion protein, and when we have high concentration of protein in the blood, we can have nephrotic syndrome. So every time we give IVIG or immunoglobulin replacement therapy, we should check the serum creatinine and give adequate hydration. One thing here to say that some products have sucrose, and the sucrose is known to be osmolartic product that can cause trauma in the kidneys. Hala, thank God, I check all the products that we have in Lebanon. None of those products have sucrose and under fabrication leaflet. The fourth point is thrombosis risk. Thrombosis risk we can have when we are infusing high level of protein. We can have increased the risk of hyperviscosity, which increase the risk of thrombosis risk. So every time keep in mind when you infuse IVIG, we should have adequate hydration. Finally, the fifth point, the product variability, and this is a very important thing to say, that IgA, for patients who have low IgA, those patients can develop allergy for product who have a high concentration of IgA in this product. Because why we have this allergy? Because the body is producing antibody to block the IgA, and whenever the foreign IgA, which is infused. So whenever we have this type of reaction, we will have increased risk of allergy. And one of the products that the Ministry of Health is giving us in a subsidized way have higher concentration of IgA, and that should be a reflection compared to the products that we have it as unsubsidized in the market. The last point, which is drug interaction, we should put we should be very attentive about the scheduling when to give live vaccine, because the IgA have a lot of epitopes and can neutralize the live vaccine or the inactive vaccine. So the scheduling the vaccination, we have two school here. One want to give the vaccine before 2 to 3 days before the next dose of IVIG, and 2 weeks after the IVIG, because we will have a drop in the concentration of IgGs. So now the dilemma: what should you choose? Should you choose IVIG or subcut IG? Well, we don't have a head-to-head trial, but we have a lot of meta-analysis. Those meta-analyses have showed that subcut IG are non-inferior to IVIG in terms of infection. The subcut IG have less allergy, and the subcut IG is more friendly with the patient. The patient can take it alone at home if he is well educated. And why the subcut IG may be better than IVIG? Because of pharmacokinetic. You know, the IV, when we give IV, we have bolus and trough every time. And if you look here, sorry. Okay. If you look here, we will have a trough level that is less than the trough level desired to keep the patient safe in terms of infection. So in the IVIG, we have this very risky time between the third and fourth week where the patient can coat different bacteria, compared to the subcut IG, where we have a slow release of the IgG in the blood, and where it mimics the normal trough level of the IgG that we have in normal patients, or normal person. And if you look on your right, you see that the proportion of response in the subcut IG is better than the IVIG. So what is the dosing strategies for subcut IG? This slide will talk about the subcut patients who are naive for IVIG, where we start de novo with subcut IG, where the target is 5 to 6 grams per liter. the loading dose is 0.2 to 0.5 gram per kilo divided on several days to reach a maximum. We have a maximum, between 0.5 to 0.15 gram per kilo per day. And we can see here how we have a small interval of injection of subacute IG. Then we have a more spaced one because we start by the maintenance. The maintenance dose is between 0.3 to 1 gram per kilo, and it is divided weekly or bi-weekly. What about switching from IVIG to subacute IG? Here the pharmacist should do some calculation. When to start it? We can start it 1 week after the last infusion of IVIG. We can calculate the dose by initial weekly dose by converting the monthly IVIG dose. We divide the previous IVIG dose by the number of weeks between IVIG dose, the initial dose IVIG divided by the interval week. Then we convert gram to volume times 5. I know it's a little bit Chinese. We will go to see the example here, and the example will facilitate the calculation. For example, a patient with 70 kilos, 0.4 gram per kilo of IVIG every 4 weeks equal of 28 grams. So for 28 grams, we have different bioavailability because we have different routes. So 28 grams times 1.3, which is a standard number, which 1.3 equals 36.4 gram of IVIG per month. The 36.4 gram divided by 4, it equivalent to 9.1 per week. 9.1, every time we want to convert from gram to volume, we multiply by 5. We have 45.5 milliliter per week. Hala, the adjust dosing schedule, it is on the patient preferences or the physician preferences. So if we want weekly, we can give 45 milli per week. Twice weekly, we multiply, we divide it by 2. Bi-weekly, we multiply the volume by 2. One important thing here is that the subacute IG have given us a reference how to adjust the trough level if the trough level is not met. So for this patient, for example, 70 kilo, and the trough level desired is 800. The trough level tested was 600. So we look on a table in the leaflet, and we see the difference between the target IgG trough level that is desired between the tested one. So here, 800 minus 600 equivalent to 200 milligram per deciliter. What is the dosing frequency and what is the weight of the patient? So here, when our patient is 70 kilos and he is taking a dosing frequency, and the dose he is taking it every week. So we should add 13 ml to give the patient the steady state that we are designing to get it. What about the administration? As we have said, we should educate the patient, educate the nurse, and we should have the special pump for subacute IG. So the first 2 infusions, we start slowly, and then we start rapidly. For patient less than 40 kilos, the volume should be less than 20 ml per site. And for patient more than 40 kilo, we can increase to 60 ml per site, and the rate will be low because we are afraid for some allergy for the first 2 infusion, and the rate is between 10 to 20. Then in the subsequent infusion, for patient less than 40 or patient more than 40, we can go up to 60 milli per site and 60 milli per hour per site. So the infusion will take about 1 hour as an hour. Where are the preferred areas? We have the abdomen, the thigh, the upper arm, the flanks, but we should be crucial and caution to avoid and attempt to avoid any scars, any mole, any bruise, any varicose vein, because it will dysregulate the release of the subacute of the IgG and the blood. But there remain a problem, and it is the number of deaths. Well, when we give the immunoglobulin replacement therapy, we are solving one of the pathophysiology mechanisms that I have shared before, and not all the pathophysiology. So for this reason, if you look at the Kaplan-Meier study done by Resnick and his colleague, they showed that they compared the probability of survival between patients who have primary immunodeficiency and the normal population. We will see that we will have decrease on those patients even if they are taking immunoglobulin replacement therapy. So it is due to non-infection complication. And non-infection complication is like autoimmune disease or dysregulation in the immune system. And here where we should intervene with immunosuppressive therapy. But immunosuppressive therapy like steroids can be harmful for this patient because they already have immunosuppression due to their condition. So we are starting to enter new antibodies like rituximab with anti-CD20, fusion protein like abatacept, etanercept, and small molecule like JAK inhibitors. So here it is a big table that I have summarized a lot of saying the guidelines and when to use this biologic and targeted therapy. First of all, for patients who have decreased immunoglobulin, and those patients are taking immunoglobulin replacement therapy, but those immunoglobulin replacement therapy are not so effective. We can try to test for antibody who are attacking those antibody replaced, and we can give, if it is positive, we can give the anti-CD20 rituximab. Other problem like we have autoimmune dysregulation and severe autoimmune dysregulation like ITP. The first line for ITP usually is steroids and rituximab. Here we cannot give steroids, so we can go with give anti-CD20 like rituximab or anti-TNF alpha like infliximab, CTLA4 like abatacept. Then we have the interferonopathy like Ensavi and Candle. We have overproduction here of type 1 of interferon. And we have like a GVHD syndrome, and the JAK inhibitors can be used here. And we have now a lot of data for patients post-BMT who have GVHD, and JAK inhibitors like ruxolitinib, baricitinib, tofacitinib play a major role. And in the recent guideline of EBMT, they may take the first line instead of steroids when we have eruption or GVHD. And finally, for patients who have gene defect like granulomatous disease and Westcott-Arlach, here, as Dr. Irani have said, we should go to the gene therapy or enzyme replacement therapy. We can go and give some mTOR inhibitor to reduce the lymphoproliferation of those type of PID. Finally, I will talk a little bit about the antibiotic in a primary immunodeficiency, because even when a patient is taking immunoglobulin replacement therapy, he can get recurrent infection. What is the most used antibiotic to put the patient in prophylaxis to not get infected? We can add azithromycin or amoxicillin. Some specific PID have to be given some specific type of antibiotic, like in CGD or granulomatous disease. We can give Bactrim and antifungal, which is specifically like itraconazole. Why? Because those patients can have aspergillosis. So for a prophylaxis to aspergillosis, we can use the itraconazole. For SCID, which is the severe combined immunodeficiency, we can go with Bactrim to PCP prophylaxis. Other patients like asplenia or hyposplenia, those patients have higher risk to have infection with encapsulated bacteria. For this reason, we can go and give them amoxicillin as prophylaxis. For patients who have complement deficiency, we have here a lot of poor wound healing, and one of the major bacteria infection is the Neisseria. Here we can go with penicillin daily or plus vaccination. And finally, the post-severe infection complication, like when we have a end organ damage, when we have delayed PID, we can go and give azithromycin as long-term because it has anti-inflammatory effect other than anti-infective effect. And finally, before immune reconstitution and post-BMT, here we can go and give a whole of arsenal of antibiotic and antiviral like Bactrim for PCP, like letermovir for CMV, like valacyclovir for herpes reactivation, and we give tefluoroquinolone every time we have ANC less than 500. A little bit about cost effectiveness, and it is very important. You look, I didn't put any name of brand, but all of this brand are linked to the Lebanese market. So we have different type of brand, and the cost is a little bit fluctuated. We have the IVI brand 1, which is 184 million. Brand 2, we have 275 million, and which put a very big problem on the accessibility on those drugs, because it is very costly in a place like Lebanon. If you compare the cost or the monthly cost of this therapy to the GDP per capita for this therapy, it is very high for this patient. One solution can be the subcut IG. Why? Because those calculation only on the cost of the drug. We know that the subcut IG can be given at home if the patient have the proper pump and proper education. So it will not need to be hospitalized and to pay to the hospital every month to get his dose. So my take-home messages, finally, we should emphasize the medical education and awareness, especially for all healthcare player. We should do the screening, and the screening can help a lot to diagnose and early diagnose before complication or manifestation, the PID. We should individualize the immunoglobulin replacement therapy. We should know who are the patients that can benefit from product who have lower IgA, who are the patients where we should calculate the adjusted body dose and not the and not the actual body dose. We should do a precise genetic and functional diagnosis, as Dr. Carla Irani have said. We can now use targeted therapy like JAK inhibitors, like CD20, like abatacept, that can reduce the burden of conventional immunosuppressive agent and helping to walk the fine lines that I have shown you before. And finally, we can do a bone marrow transplant for patients who have severe type of PID, but keep in mind immunodysregulation plus BMT equal GVHD. So I end my presentation by saying the progress is very rapid, and look how far we come. And thank you, everyone.
Thank you so much, Dr. Ghaddar, for this presentation. Really, you've covered all therapy approaches from different perspectives. Eventually, before I start taking questions from the attendees, I'd like to have a couple of highlights. My question to you is that the first one you mentioned related to the sucrose-containing IVIG. I just wanted to highlight, it is true that we don't have sucrose in our IVIG in Lebanon. However, we have other potentially less risk, but sometimes with the increased content, it might be high risk, which is maltose containing. And sometimes some different agents have high maltose containing compared to other maltose containing, even though the safest are maltose, non-glucose anhydrate. It might be definitely amino acid, which is the safest side for excipient approach. The other thing I really would like to highlight is that definitely you've mentioned the high IgA containing IVIG, and this is something that I know it's dear to your heart and discussion that you really wanted to discuss rather than didn't discuss. So if you really wanted to highlight what are the risks of IVIG products that are highly content with IgA.
Yeah, so those products have a very can have a very tough allergy when we are infusing it to the patient. And you know, in Lebanon, every time a patient can develop allergy one time, he will not want to take the medication anymore. So it's a very big problem. And the problem now, it's the majority of our population is taking the IgA, high IgA concentration product because it is offered by the Ministry of Health. So every time we increase the population of infusion, increase the population of exposure, we will have certainly increased number of patients who develop allergy, and maybe some patients will have a very fatal allergy.
Thank you. Eventually, I have another question to you, or eventually it's not a question, it's more like a highlight. You've highlighted the value of sub-Q IG, and we all know that the supply of sub-Q IG to Lebanon is quite minimal. At the time when the company has been hesitant to introduce it to the market, and then it has been introduced, we do offer it for a set of patients, but it's not quite available for all patients at all medical center. And eventually, even though in the US, as you mentioned, sub-Q IG, it's a solution at the luxury of patient's home. It takes some time for the patients and their parents to learn how to do it, but we have all seen the educational material of the company where a 7-year-old kid can start administering, getting the regular administration for themselves. But we're not there yet, unfortunately. We can definitely try to move in that direction. Meanwhile, I have two questions in the box, and then I'll take a question from Professor Salameh. One question is by Karim Nassar. When referring to more than 2 infections, how do you distinguish in practice between common, frequent infections, especially in children, and true warning signs of primary immunodeficiency?
I didn't cap the question. She want
So
the
when you are talking about 2 or more infections, how are you differentiating between a common, frequent infection versus the true warning sign of the primary immunodeficiency? This is what her question is. So that
okay.
because
So every
pediatric or babies are doing or children are doing common frequent infections. So she
okay.
wanted to really split between
Okay.
the warning sign you mentioned that this is really a primary immunodeficiency rather than it's a manifestation of it.
Okay, if we go to the slide, I have said infections that need antibiotic. As everyone knows, when we are
You
talking
need to
about
share back
pediatric,
your slide because we are not able to see if you are
uh,
referring to your
okay,
presentation.
when I put it on my slide, I have said bacteria infections that needs antibiotic, and we all know when we are talking about children, most of the children when they are developing infection, that the infection goes alone. It's a viral infection, so it is a little bit nuance, Hony, and when we need antibiotics 3 times for an infection for a child, it's better to go and see and to refer him to a specialist, because it's increased number of prescribing antibiotic for a child, that the infection can be go alone, because the 70% of all infection for children are viral and does not need antibiotic.
All right. Another question, do you observe any increased infection risk during the IVIG to the sub-Q IG transition phase? So at the time when the patient will be kind of off to move to the sub-Q IV, do you see or observe any potential increased infection? I don't think so. We didn't see that.
We
All
don't.
right. Professor Salameh, you have a question?
Yeah, actually, it's more a highlight than a question. I would have liked that we talk about some preventive measure. Now, I know that the disease by itself cannot be prevented, of course. It's a genetic thing. But preventing infections, I think that treating any primary immunodeficiency patient should be like treating any other immunosuppressed patient. So giving him by pharmacists, I'm talking about community pharmacists, they should provide more advice, maybe related to preventing infection, hygiene measures, wearing masks in crowded areas, avoiding eating raw food, sushi, all these kind of really simple measures that can sometimes be useful for the patient to have a lower risk of getting an infection. So that's what I wanted to say. As in any immunosuppressed patient, whether an HIV patient, or we're talking about a cancer patient, or we're talking about a patient with transplantation of any kind. So these patients, I think that they would benefit from these kinds of advice. That's what I wanted to add. Thank you. Anyway, it
Thank
was
you.
a great presentation. Just this particular prevention point, it's dear to my heart, actually. Thank you.
Right. So
Thank
I
you.
have one question also. I'm gonna go ahead and read. What are the biggest challenges hospital pharmacists face when managing PID treatment, particularly given Lebanon's current healthcare and supply constraints? And what role can pharmacists, with the support of the OPL, play in advocating at the Ministry of Public Health level to improve access, ensure medication availability, and strengthen the care pathway for PID patients in Lebanon, in your opinion?
Okay, as I have said, the problem in the IVIG and the PID treatment and the immunoglobulin replacement therapy is the accessibility. You know, Dr. Rony, more than me, that we have a lot of problem of clearance for this patient. Those patients cannot pay for this big amount of money, and we are the way that we are the challenging way to take the medication from Ministry of Health may be sometimes very delayed. And we have seen, all of us, the delayed diagnosis and delayed treatment of the PID. It's a very big problem. So as a hospital pharmacist, first, we have a problem in the clearance, the accessibility of this drug. The second point is about the adherence of the patient. So the patient, as we have said before, he should to take the immunoglobulin replacement therapy, if sub-Q, every week, and if IVIG every 4 weeks. The bigger number of patients, once they get the immunoglobulin replacement therapy and they are good in good health, they won't come anytime soon in the hospital, even with physician pressure. So we have a big problem here. And the third point is about the diagnosis of this patient, because as I've said, they are presented to different specialties, not the specialized one. So what we can do at level of OPL, first of all, make the drug more accessible, choose a good brand where we have a good repartition of the IgG, IgM, and IgA, and increase the policies and the webinar, like this webinar, increase the awareness about the PID. Like Dr. Carla Irani, it's more common than we think. When I was in the pharmacy school, when we are talking about PID, at my background, at my memory and my background, I remember the Lebanon who is kid patient who are very, very rare cases. But it turned to be the PID is very common. We are talking about 6 million people, 90% undiagnosed. So this is the 3 points that we can do at ministerial and OPL level.
Thank you. Eventually, I want to really put on the table, before we move to our next speaker, I really want to put on the table something that that currently is quite important to consider for the access, because you mentioned the access and because you mentioned the financial constraint. There has been many countries around the world that are using the ideal body weight approach. First, the ideal body weight approach for dosing of IVIG, it provides rounding down for the vials because we are using less vials. It provides continuity of therapy because in the time of shortage and unavailability of the supply, we really need and care to provide patients, all the patients with IVIG without interruption. And in order really to cater for the availability, this is what currently we are doing. We are using the ideal body weight approach. This way, and there has been several studies across the world using the ideal body weight approach, and eventually, even though this is not standard practice, but it is definitely a used practice, an efficient practice, and it has not provided an undervalue in the care for all patients who are getting therapy of IVIG. So really, I really wanted to put this on the table because it's quite valuable and many countries are using it.
I want to add something when you highlighted this. We have a problem in Lebanon also, that all the patients who have agammaglobulinemia or low level of IgG take 0.4 to 0.6 gram per kilo of IgG, and they don't test for a trough level every 3 to 4 weeks. So maybe with a high dose on adjusted body weight or an actual body weight, those patients can benefit from seeing the trough level. If the trough level is met, we can reduce the dose and round down and use the ideal body weight, as you have said before.
Great. Thank you so much, really, for this comprehensive approach of presentation. We're gonna take the time to move to our third speaker, Ms. Hala Takieddine. Ms. Takieddine is president of the Association of the Lebanese Patients with Primary Immunodeficiency, a dedicated patient advocate whose personal experience with PID drives her commitment to improving diagnosis, treatment access, and quality of life for the Lebanese PID community. She is also self-empowerment coach, bringing a coaching approach into the medical ecosystem to support patients holistically, fostering resilience, self-advocacy, and emotional well-being. Her presentation today will be entitled Living with PID, A Patient's Voice, Patient Advocacy, ALPPI Journey, and Lebanon's Call for Action. The floor is all yours.
Good evening, everyone. It's a pleasure to join you this evening.
Your voice is quite unheard.
Really? Is it better now?
Yes, in a way.
Yeah. Good evening. It's a pleasure to join you in this scientific session. It's great to be hosted as ALPPI president by the Order of Pharmacists, and thank you for the moderators and thank you for the speakers for this thorough scientific session. Actually, tonight I'll be the voice of the patients, of the PID patients in Lebanon, and I'm gonna give you our perspective of what PID is and what living with PID looks like. So this is our journey from awareness to action, and this is what we are looking for. So PID can't wait. We can't wait. This is the slogan of this year's PID week. And we really need to look at another perspective for PID, and this is the patient reality perspective. What is PID? For a patient with PID before having a diagnosis, how does the life look like? Well, let me tell you, and what I'm saying here is from experience, from my own experience for the past 18 years and from the experience of the patients in our association. Actually, the feeling that something is wrong, but not knowing what it is, it's annoying and it's irritating. So you are sick all the time, you have repeated cycles of illness, you recover, you take antibiotics, and this recovery doesn't last long. Then you have a relapse. At symptoms that are very random sometimes, they just hit suddenly and fiercely, and sometimes they just stop you from continuing your ordinary life. And here the patient is stuck with searching for explanation from different sources without getting clarity. And now the daily life becomes shaped by unpredictability, which is emotionally and mentally distressing, not only to the patient himself, even to the family and everyone around him. And this leads, of course, to less productivity at school or at work, and getting sick without understanding what the patient did wrong. So here there's also the feel of guilt. Why am I getting sick all the time? What have I done wrong? Well, it doesn't end here. PID has another phase. It's post-diagnosing PID. So PID for scientists, for doctors, for researchers is a medical term. For patients and families living with PID, it's another story. It's the story of a life that suddenly becomes structured around infections. We fear the complication of infections. We fear the organ failure, and we are constantly vigilant. Even if you want to go out, as you mentioned, Dr. Salameh, we have to be very careful what to eat, whom to shake hands with. Shall I give this person a hug? Would it be a deadly hug? So this vigilance surrounds the people all the time. And of course, when you get a diagnosis, this is not the end of uncertainty, because first of all, it's a lifelong adjustment to everything. You need to take treatment, or if the person as a child needs to go into bone marrow transplant, then this is another change in life. And what is irritating for this patient is that the treatment is not optional. So as a patient, it is not an option for me not to take the treatment. If I want to live, I need to take the treatment. And what the treatment compromises is a lot when it comes to the continuity, when it comes to a life burden, when it comes even to having access and being able to get this treatment. So as Dr. Ghaddar said, we have a wide range of IVIGs or subcutaneous. Sometimes it's not the choice of the patient which one to choose or what kind to take. Even if it has high levels of IgA, this is the only one available, so I need to take it. So really, it is a life burden for the patient. And let's not forget that mostly the patient has to do the coordination between the doctors, the pharmacists, the insurance companies, and this is something that no one can do for the patient. So as a doctor, as a patient, I need to follow with maybe several doctors. My immunologist should be the chef d'orchestre of these doctors, so I cannot get a fragmented healthcare from doctors. The pharmacists should know what I have. Even if I want to go get a simple medication from the pharmacy, I should tell my story. And the insurance companies, usually they're not very helpful when it comes to this. You get exclusion on any thing that might be related to immunity, and it is really a wide spectrum of diseases that can relate to immunity. So here we get that as I said, it's not only a medical term, it's a life. It's a complete change in life. And what we lack here is that we need to stabilize the condition, but stabilizing the condition depends on the treatment we get and whether this treatment is available. So let me tell you a short story here. In 2019, when the ministry was not importing neither subsidized or unsubsidized IVIGs. The patients were left alone to get their IVIGs. We had to get them from different suppliers. We had to get them at expensive prices. And on top of that, we had to skip doses. And too bad, many of us got into health troubles and organ damage. I personally was about to lose my eye due to a very severe sinus infection because I was taking half the dose required and I was extending the time to 6 or 7 weeks because I was paying $3,500 to get these medications that were not even monitored. So when we talk about PID, it's not a medical term. Science here as a patient is valued by the care we get from doctors and pharmacists, but there is a lot more to it for a person and a family. How many patients with recurrent infections could have an undiagnosed PID? As you have mentioned, the estimates as per the Primary Immunodeficiency Week resources and the ALPPI resources, they are 70 to 90%, and with an average 2-year diagnostic delay. And that's really a long, long time to get a diagnosis. Now we ask ourselves, what is the collective role of healthcare providers and patients in shortening the diagnostic journey? Because we need early diagnosis, because as we all know that PID is treatable, it is rare, but it is treatable. What's crucial is getting the diagnosis. And here there's a role that should be played by both parties, the healthcare providers and the patients. And when I say healthcare providers, I mean the doctors at this stage, where the doctors need to be vigilant to look for signs and not to consider that rare does not exist. And the doctors need to refer to immunologists when they have doubt. And when it comes to patients, patients need to be clear on the symptoms they're facing, on the medications they're taking, on the recurrency of the infections, so that really when they seek diagnosis, they have all the information ready to facilitate the diagnosis. Now, who advocates for PID patients in Lebanon? We are advocating for PID patients in Lebanon. We're the Association of Lebanese Patients with Primary Immunodeficiency. We are a registered NGO since June 2025, and it is a patient-led organization supporting individuals with PID. It is an initiative that started a few years ago in collaboration with ALPPI, facilitated by Dr. Carla Irani. Thank you, doctor, for all the efforts. And ALPPI is a nonprofit international organization, and it is a leading advocate for PID in the world. Now, the role that ALPPI plays is to collaborate with different parties. They collaborate with patients, doctors, politicians, regulators, and even the pharmaceutical industry to improve awareness and to improve access to early diagnosis. And of course, to promote the optimal treatments for PID patients worldwide. 78 countries are members in ALPPI. We were the country number 74 to join. Who can join ALPPI? As I mentioned, ALPPI is a patient-led organization. So patients can join, family members can join, and doctors can join. ALPPI is supported by a medical advisory board, but doctors are not part of the association. How is ALPPI supporting patients? We are improving access to early diagnosis by raising the voice, and we have done several events during the PID week, and we are concluding the PID week with this event. Thank you. We are advocating for access of treatment. As I mentioned, we are facing difficulties in getting IVIGs, and we are trying to raise the voice. We are trying to contact the Ministry of Health. We are trying to make IVIG accessible to all PID patients at a good price, let me say, or whatever is available that is most suitable at this stage. We have created a PID community for peer support. I spent 18 years having PID. I thought I was the only person in Lebanon who has this because of the stigma. No one mentions immunity issues. They are still on the red flag. So we have created this support for the families and for the patients themselves. We support the holistic patient care, and this means that the patient needs not only physical care, they need also mental and emotional care, and we always do sessions to support them. And of course, we empower the patients through education. As we are doing tonight, we have invited the patients to join us for this session so they can be aware of how pharmacists can support. And of course, we are reaching out to everyone to help us to hear us. Now, what is the Primary Immunodeficiency Week? It is a global awareness campaign held every last week of April, and it aims to increase understanding of innate errors of immunity. This is the scientific name, but we still find it much easier to say PID. And this is done by educating the public, healthcare professionals, and policymakers. And the campaign focuses on promoting early diagnosis, improving access to appropriate treatment, and advocating for better care and quality of life for patients worldwide. It also highlights the importance of timely recognition and intervention to prevent complications and save lives. Dr. Ghaddar, you have mentioned that it was maybe 45 months to get a diagnosis. These were the numbers like 10 years ago, and the number now is 2 years, and we want to make it even less So we save lives and we intervene at the right moment. The 2026 campaign is, as I mentioned, We Can't Wait. And this is the poster for We Can't Wait. We are calling for early diagnosis and timely treatment and support for primary immunodeficiencies. What we value from pharmacists. We value from pharmacists noticing recurrent infection patterns over time. We know that in our society, the pharmacist هو الحكيم، بروح عند الحكيم بسأله شو لازم آخد. Usually this doctor or this pharmacist is in the neighborhood, so he knows us and we visit him often, and it's the role of this pharmacist to notice that this patient is asking for a lot of antibiotics for infections. So this is a warning sign. And of course, we need to be attentive as pharmacists to the frequent antibiotic use. Why is this patient using frequently antibiotics? And why is this patient jumping from one antibiotic to another or even using the injections? So also this is something to watch for. And of course, we want to encourage patients to seek medical follow-up, because when the pharmacist in the neighborhood says, I think you should see a doctor, it's better to see the doctor, we still believe in the power of this pharmacist and we should take it to our advantage as patients. And here's the big problem that we are facing, the consistent supply of IVIG or even subcutaneous. We don't have this the pleasure of being at ease with the consistent supply. So sometimes the medication is available, you get used to one brand, the body gets okay with a certain brand, then suddenly this brand is not available and the patient here is stuck. Should I wait or should I take the medication? No, of course, I should take the medication, whatever it is, even if it has high IgA, I need to take it. And we want pharmacists to ensure the safety and efficacy of immunoglobulin preparations. You have mentioned, Dr. Ghaddar, the protocol that should be used. And I see in hospitals that this is given by the pharmacists. But let me tell you something. What's in the protocol on the system is not always done with the patient by the nurses for different reasons. Maybe because they lack staff, maybe it's the time, maybe, I don't know, it's the lack of information. So we want pharmacists at hospitals to reinforce the protocols and the importance of following these protocols for PID patients. And of course, we want pharmacists to participate in patient awareness sessions, the way you did today. Thank you. Having the pharmacists on board, knowing more about PID is a plus for us PID patients. And of course, when we say pharmacists, we say PID patients. These PID patients have other medical issues also that go along. So it's not only the immunoglobulins, they take other medications. And here's the role of the pharmacist to make sure that the prescribed medications do not have any counterindications with the treatment the patient is taking. As I said, we can't wait. We can't wait for repeated infections to be seen as signals, not just prescriptions. We understand that pharmacists do not diagnose, and this is not their role, but they are often among the first to detect the patterns that need clinical intervention. And we'd like to stay in touch with you as ALPPI. Please follow us on our social media, and we're always happy to work together to raise awareness and to turn this awareness into action. Thank you.
Thank you so much, Ms. Takieddine, for really highlighting the role of ALPPI, but also from speaking from a hurtful heart of the suffering of PID patients. We do understand that there has been a lot of lack of knowledge, I would say, and probably fear from the word of PID. I think every pharmacist, because they don't know much about it, because they haven't seen it, and because even in the hospital and the medical center that treat, and because it's more linked to a pathophysiology, probably pharmacists felt for some time they are far distant from linking themselves like any other patient they link themselves to in general. I really want to, before I open the floor to questions and interaction among the speakers, I really want to go back to your slide that I took a picture of, noticing recurrent infection pattern over time, where you are really asking the pharmacist to notice the recurrent infection. And here I really want to bring it back to the OPL. First, there are responsibilities from both sides. First one is that PID patient is to go to the same pharmacist to get the medication, because in the US, or if in Europe, we have profiling systems. So eventually we have tendency to identify if there is an infection happening over time and the frequency of the infection. Unfortunately, in Lebanon, sometimes the pharmacists are having I would say, initiative to have a system that will help them to remember their patients and profile their patients. And in that perspective, they will be able to identify that she is coming back with an infection for her daughter. Last 3 weeks, she came in 1 month ago or so and so. So profiling the condition in the community pharmacy is really what would trigger pharmacists to identify and help you to refer to an immunologist. But also, I really want to make sure that, because we do represent the OPL after all, pharmacists are not physicians, and we don't have the same credentials, but we are the drug expert. And because we are the drug expert, and once we understand the pathophysiology of the disease, definitely we can help patients from a drug perspective and adherence guidance perspective and counseling perspective, and definitely we can refer them to the immunologist for adequate diagnosis. So having this being said, I also wanted to go back to the fact that you mentioned at the end that sometimes the order is not whatever is being administered. This is something really probably because the order was taken on paper and then it was transcribed to a different mark sheet. Things are changing over time, and we are in a health information system where things are automated, and we really hope many medical centers will move to automated system and automated prescribing approach, which really will diminish and minimize the potential risk of error that you have discussed in your presentation. Dr. Salameh, Professor Salameh, go ahead.
Yeah, I would like to add to what you're saying that we as OPL, we have a high responsibility, of course. I guess that it's not only pharmacy, it's all healthcare professionals who should be working together. And we as OPL, we already around 3 years ago set some ground for a national pharmaceutical strategy. And the motto was leave no one behind. And I guess that what we are discussing now is really one of the situations where we feel that we are not doing enough. So yes, I guess that there's something to be done. We as an order, we have to move, we have to do something. And I guess that we have to do it in collaboration with other healthcare professionals. And here we were talking with Professor Irani about the fact that we need to approach again the Minister of Health. We need to talk about registry. We need to talk about collaborations. We need to talk about data ownership, because obviously this is one big problem. But eventually it has to be solved. It has been solved all over the world. Why not? Why not in Lebanon? So there's a lot that could be done. We have lots of responsibilities. Let us hope that we have peace of mind, in order to act. The problem is that we've been trying, and there are always some hassles and always some political security issues, the war, the conflict. So I hope that we will be able to work together, because we cannot do it on our own. Patients cannot be alone, and pharmacists cannot be alone, and physicians not alone. Everybody, we have to do it all together. And I can say that for Mrs. Takieddine, if you would like us to really sit together and think about a collective action, maybe an action plan that includes several items, yes, we are ready to do so, and to help and work with you. Thank you.
Thank you, Professor Salameh. I have eventually, Ihsan has something in the chat, but eventually you've answered it. It's related that we really need a national effort and a clear pressure from the Ministry of Public Health, and we need to really consider lobbying for this issue with this disease representative. Eventually, just
Exactly.
before giving back the word to Ms. Takieddine, and in preparation for a closure, I'd like to have a final word by Professor Irani, then Dr. Ghaddar, and then Mr. Takieddine, and we close accordingly. Professor Irani, any last word before we close?
Thank you again. I would like to end on a positive note. It is true that a lot has to be done, but we did a lot already. Creating this association for patients is a major achievement, but I think also we need to encourage more patients to join this association. There is still a lot of stigma, as Hala said, and also patients shy off. In our culture, there's not a lot, but encouraging patients to join this association actually will help a lot for this. We will, the creation of this association was not easy. It was very challenging, but we did it. And again, I think we will achieve the registry creation, I hope, one day. So the positive note is we are doing a lot. Thank you a lot for the pharmacy, the Order of Pharmacists, for all the participants, the great moderation. And this is not such a rare disease, but with the collaboration, we can diagnose better and treat better our patients. Thank you.
Thank you so much. Dr. Ghaddar, any last word?
Yes, I want to thank the organizer, especially you and Dr. Salameh and Professor Salameh, to give us this awareness. And I am in the oncology field. I didn't know about this disease, and it is very, very common disease. So it's good to prepare this PowerPoint, to understand more, to give the awareness to my colleague tomorrow and my community pharmacy friends. So this type of medical awareness, this type of organization like Dr. Carla Irani is very important. And it's very important to look at Mrs. Hala Takieddine and to see how much she is involved, how much she knows about the rate, about the AGA. She knows very good about her treatment. So it's something that's very good to see and to say. The point that we argued about it before, that we need more accessibility, we need more cheaper drug to be accessible for a country like GDP for $400 for a drug that costs $500 per month, which is tremendous. And we need more education and more accessibility at home, so the patient can give the sub-Q, like you have said, and they can take it at home. 7-year-old child can take it at home. Why not the Lebanese populations that are the most smart population?
Thank you. Ms. Takieddine, you had a question and then the last word as well. So combine both.
Yeah, I wanted to acknowledge the scientific and the social responsibility the Order of Pharmacists has took tonight to collaborate with ALPPI and to advance the awareness and to advance the action, the accessibility of treatment. Thank you, doctors, for this wonderful session. We cannot do without you. As Dr. Irani mentioned, the association had a difficult delivery, and due to the stigma around primary immunodeficiency, we are still facing difficulty to get patients on board. What we are counting on is you, doctors, to help us, to follow us on our page, to share maybe the content, to share educational sessions with us, so we get more visibility and the patients would feel that we can be ordinary patients. We can say we have PID. If I had cancer, it would have been easier to say I have cancer, and maybe people would have empathized with me more than saying I have a primary immunodeficiency, because primary immunodeficiency is still not understood. And it is still considered, I have to say it, AIDS. So we need to highlight the difference. And this difference is not something that the public only doesn't know about. We face situations where even healthcare professionals get things mixed up. So we want professionals like yourselves to support us. And thank you again for this wonderful evening.
Thank you so much. Professor Salameh, you
Yeah, I would
conclude.
like just to thank Science Pro, particularly Dr. Carla Abu Salwan, for organizing this wonderful work and for being there and for really helping the OPL Scientific Committee in all these important events. So thank you, Carla. I think the recording will stop.
Thank you as well. I would like really to really thank Ms. Carla Awsirwin as well, and all the organizing committee, Dr. Hala and everyone, Dr. Salameh as well. Really, it was an amazing webinar. It is really well needed, and have a great evening, everyone. Thank you so much.
Thank you. Bye.